Welcome, everyone. Hello. We'll just give a few seconds for everyone to join there. Hello, everyone. So as you're coming in, please do say hi in the chat. Maybe your name, country, profession, and our presenters and moderators will do the same. So hello, everyone, and welcome. Welcome to this webinar series. So simpler actions for better nutrition and better outcomes after hip fracture and other fragility fractures. This is part of the FFN Orthogeriatric Care Education Programme. My name is Mary Walsh. I'm a physiotherapist by background and I manage national fragility fracture audits in Ireland. So from our experience, I can say that 2026 is the year that Simpler is taking Ireland by storm. We have huge engagement from our interdisciplinary teams across the country. So please do keep those comments in the chat coming. Your name, country, and profession. Great to see everyone. So this educational module will be delivered through 4 interactive webinars. So they're designed to help translate evidence-based nutritional recommendations into everyday clinical practice for hip fracture care. And across this series, we'll explore practical strategies and tools to support healthcare professionals, patients, and carers in strengthening nutrition and improving recovery and outcomes. So each webinar is offered in 2 live sessions that will accommodate different time zones, allowing participants to join from anywhere and select the session that best fits their schedule, while benefiting from, I guess, interactive learning, real case studies, and shared insights. So in many places around the world, we are getting better at doing things like nutritional screening, diagnosing malnutrition, things like providing high protein diets and supplements. But as this current session will highlight, we're not paying enough attention to making sure that people are aware of their diagnosis, that they understand really what that means, and are engaged in shared decision-making about their treatment options. So that's why the two simpler 6 questions everyone should ask are they aware of nutritional risk status, and have they received nutrition information? So identifying nutritional risk status in patients with fragility fractures is a crucial first step towards improving outcomes. So missing or delaying the identification of nutrition risk can have serious consequences. And if the patients are not aware that they're at risk of malnutrition or that they're already malnourished, they're less likely to follow nutritional recommendations. And this might lead to slower healing, more infections, increased confusion, longer hospital stays, and higher chances of readmission. Whereas when it's identified early, it allows for timely interventions to improve recovery, reduce complications, and lower costs. And many patients aren't given around the world, they're not given clear information, and they might not understand why that matters. They're more likely, so if they do understand it, they're more likely to take an active role and follow recommended nutritional actions like eating high protein foods and taking oral nutritional supplements. So before starting, let's just take a moment for a brief survey, and this will appear on our screens. So there's 2 questions that we want you all to think about to start off. Firstly, in your setting, what percentage of hip fracture patients who are likely to have a good memory or understanding actually know that they're at risk of malnutrition? If you could maybe estimate that, click what one of the options you think most applies. And also, what percentage of hip fracture patients, again, who are likely to have a good memory and understanding, are given information about nutrition? So click what you think there. And we'll just leave a few minutes for you to think and enter those questions based on what you know from your setting. As answers are coming in there, I'm delighted to see people from all over the world here. Australia, UK, Scotland, Northern Ireland, Iceland, Brazil. Italy, UK, brilliant. Greece. And thanks for that, Jack. Yes, do please feel free to pop any questions in here as we go, and we'll come back and answer those. Maybe not me, but the experts will.
Do we have the answers for this one, Katerina, or is this one of the ones where it's just a self-vote?
Oh, we have the answers. The answers are in. So, okay, so what percentage of hip fracture patients are know that they're at risk? 2/3 saying less than a quarter. So that is telling. And how many are given information? It's kind of a split between less than a quarter and less than a half. So, so hopefully over the course of after this webinar, we'll be hoping to boost those numbers a bit. So thank you so much, everyone. I'm going to hand over to our next speaker, Maria. So, and Maria will introduce herself. Thank you so much, everyone.
Thank you. I am Maria Panurgia. I am an orthogeriatrician in the UK and recently appointed as the NHFD lead here. So let me try to share my screen. It worked before, so I hope it will work now as well. I think this is the right one. Yes, okay. Can you see it? I think you're on mute, Jack. I can see your mouse.
Enter presenter mode, I'd say.
Yeah, we'll try to. It does not work for some reason. There you go. Yay.
Perfect.
Okay, thank you. Okay, I have the next two presentations. The first one is what is the nutrition risk status, who affects and how to measure it. So we know that, and we know that from our clinical practice and from research is that up to half of our fragility fracture patients are already malnourished when they arrive at the hospital. And also we are aware that without targeted nutrition support, we can go up to 2/3 of our patients at the time that they leave the hospital that they are malnourished. So all this effort is to try to reduce and intervene a little bit earlier than when the patients leave the hospital. So let's see a little bit of the definition so we are all on the same page. Well-nourished patients, well-nourished people are those that or they are assessed and they have declared and classified as well-nourished using a valid diagnostic tool as the mini nutritional assessment short form or the SGA, the subjective global assessment, or the GLIM. And they have adequate muscle and fat stores, and they are eating and drinking enough for their needs. At risk of malnutrition, there are two different categories that they are fall in this area. They are all hip fractures, or not only, or other patients that they have a positive nutrition screen, but they have not been given yet a thorough nutrition assessment to be set in the right classification. And or they are those that they have been assessed, they are not malnourished, but still they are not meeting their nutrition needs, so they might become malnourished. And going down to malnourished are the ones assessed using the one of the valid diagnostic tools. They will have inadequate muscle and fat stores. that and they will not receive enough nutrition for their needs. Please remember, and that's why the images here you can see obese people, that malnourished people can be also be patients with high BMI or with normal blood test results. So who should be offered information about the nutrition risk status? We are talking about mainly hip fractures in this group. So of course, anybody with a recent hip fracture, anybody else screened as risk of malnutrition, and everyone assessed and diagnosed as malnourished. Going to the hip fractures, they need all of our hip fracture patients admitted to the hospitals need to be considered as at risk of malnutrition until they get assessed with the screening tools that we said as well nourished. And as they are, when assessed, also not at risk of becoming malnourished. So that means that we are also offering the right nutritional support to our patients. The ones that they are screened as risk of malnutrition, they are not only the hip fractures, but also other fragility fracture patients that they have been screened, and also patients that are overweight or living with obesity. And as we said before, that they are at risk of malnutrition. And the people that they are malnourished use the use the validated screening tool. So how can we measure if the system, so the patients, the notes that we are putting at the chart of the patients, and the clinicians are aware of the nutrition risk status. The best way forward is to audit. So take 10 charts, then take 10 notes of the patients, and if there is, and see if there is documentation of evidence that the nutrition assessment and a discussion with the patient or the carer has taken place. You can also ask 10 patients that they have good memory if they have been provided the results of the nutrition assessment. And ask also 10 clinicians at the team meeting what, as we did today, what proportion of patients who are malnourished or at nutrition risk and have a good memory are aware of this, have we communicated with the patients. All this will give you a good understanding of how much the awareness is not only within the team, but also the patients, their carers. Are we giving the information? Because all this will make them, and we will see in the next presentation, aware of the malnutrition, and we could help them with their nutrition status. Now, I should know how to stop share. There you go. Okay. So I will go to the next presentation, hopefully, and it should be this one. Okay, can everyone see this? Node is okay? Yes, thank you. All right, so why it matters? So it matters, we will discuss why it matters for the patients and why it matters for the system, the hospital, the clinicians. So for the patients, because early risk status identification improves, of course, the nutrition care. And it is important for our patients to be aware at nutrition risk, because it will help to make an informed decision about the treatment. And also they are more likely, the ones that they are aware, to follow the nutrition advice. So, and once we have established this culture in our team, the team members that are aware that their patients are in risk of malnutrition, they are more likely to give the right advice and to prescribe treatments. So let's see what malnutrition does at the to all patients. So malnutrition leads to worse physical and functional outcome and increased risk of harmful fractures, and also increases complications, including infection, wound reopening, sepsis, and acute respiratory failure. And we will see after that, because of all of this, it can increase the length of stay in the hospital. So it is all interrelated. We know that hip fracture patients with malnutrition have 2 times higher in hospital mortality and 3 to 5 times higher mortality at 3 and 12 months. So you can understand the importance of the screening, assess, and treat. Going to overweight and obese hip fractures that it is stressed in the various slides. What is happening? We know that malnutrition is linked to more times higher odds of delirium and delayed mobility, and 4 times higher odds of 12-month mortality. So please not only look at the very malnourished, low BMI patients, but be more aware also for the higher BMI ones. Malnourished hip fracture patients have lower rehabilitation efficiency and, of course, poorer functional outcomes. And being malnourished, you will have a delay on your fracture healing, because the fracture healing needs adequate nutrients, energy, and cellular activity. And these two combined, the lower rehabilitation and the delayed fracture healing, of course, will delay the hospital. And now we are going to talk about this, which is about why it matters to healthcare workers, hospitals, and healthcare systems. If the patients and teams are not aware of nutrition risk, then the right care is less likely to happen. And at this point, it will be increase the workload and inefficiency in the system. There will be poor coordination and longer stays, as we saw before, and that will reduce the bed availability. And because of the rehabilitation delays and probably the fracture healing later, they can be higher readmission rate that can lead also to clinician stress and burnout. So at this point, it comes without explaining it that we will have worse economic outcomes. So we'll have higher treatment costs because complications and non-union may require revision surgery and extra tests, more medications, more chest infections, etc. Higher hospital costs of the longer stay in the hospital. And they can arrive to 20 to 50% more cost of the malnourished patients per admission, And of course, it is the long-term financial burden to the whole system. So that's from me. And I need to stop sharing. Thank you.
Awesome. Thanks, Maria. Julie, I believe you're up with patient scenario.
Yes,
nice to
that's
see
me next.
Yep, nice to see a few questions coming in there as well. So we'll do that. But also, while we're waiting for the polls to come in, we might address some of those questions as we're waiting on people to fill out their polls. So please keep the questions coming. Over to you, Julie.
Okay, so the important thing about the Simpler program is that it's very, very, very embedded in practice. That's what this is all about. So as a consequence, we like to use patient scenarios, all of which have been developed based on real patient cases with clinical experts. So here's one for you to think about, so that you have a patient in your mind when you're thinking about some of the things that we're discussing today. So let's take Mrs. L. She's an 82-year-old woman, and she's been admitted to an orthogeriatric unit or an orthopedic trauma unit with a fragility hip fracture after a fall at home. Now, on admission, her screening tool was negative, so she was screened as being negative for being at risk of malnutrition. Her BMI was 30, and she was reported as being weight stable in that she'd neither lost or gained weight recently, although she did have some problems with fluid retention. She's reported no appetite at present due to her pain levels because she has a broken hip. So what do you think is the most appropriate next step to optimizing Mrs. L's recovery based on her apparently high nutritional status? So you can choose, would you delay nutrition risk assessment, status assessment and intervention until after her surgery, focusing first on the orthopaedic procedure? Would you say Mrs. L has had a hip fracture, so start simpler supportive care straight away as surgery is not until tomorrow? Or would you proceed with standard post-operative care, assuming nutrition will improve once mobility and appetite return? So we'll just give you a few moments to have a think about which of those would be the best choice in Mrs. L's situation. It should only take a few moments for everyone to make a little decision about.
While people are thinking about that, I will go back. So Megan Zurich from the United States, thanks Megan, has put in a question there about who can do the nutrition assessment, which is often a challenging question. And in her setting, it's often tasked to the nurses, but as we know, nurses are very busy and have many other things to assess and chart as well. So I put something in the chat saying, well, in our hospital, what we did was we've trained our nutrition assistants to do it, but the dietitians still countersign so that we can get funding reimbursement that's needed. We've also got good geriatricians so they can make the assessments as well. And we often train some of the other medical staff so that if it's missed for some reason, somebody else can pick it up. I do think, though, the question Megan raises is really important because it's about how much value is put on nutrition. I know from some surveys we've done that across, for example, the UK, because there's funding associated with providing people with oral nutrition supplements, everybody gets the oral nutrition supplement. Well, a lot of people do. But they don't know what it's for and they don't have a diagnosis. And so they get wasted a lot. And then people can be saying, we're doing all of this busy work and it doesn't actually make a difference. So I think it's important that people understand that awareness is just as, if not more important than actually doing something that seems a bit more physical and a bit more meaningful to staff. So that's a good thing just to remember in the background. Okay, so we got the answers up. Julie, back to you.
Okay, so thanks for that, Jack. It's all about, what you're saying is this is all about working together as an interdisciplinary team to make sure that everybody is involved in understanding nutritional status so that the right interventions can be in place. So just a slight difference of opinion here in that most people have said that because Mrs. L has had a hip fracture, start simpler supportive care straight away as surgery is not until tomorrow. And that's very much what the simpler programme encourages, because we know that hip fracture patients are going to be malnourished or certainly at a very high risk of being malnourished just because their nutrition status on admission doesn't suggest that it's particularly worrying. We know that it is. So in a way, question one's kind of a second right answer, if you like, that understanding nutrition status isn't that important at that time. So you're going to go with preparing the patient for surgery. But most importantly, you recognise that nutrition status is going to be really important and that you start supportive care straight away is the really most important thing with this. So I'm just going to share my screen now and we're going to move on to take this a little bit further. So just give me a moment while I find the right file and hope that I'm sharing the right thing. Hopefully you can see my screen and it's
perfect.
on the right front page. Thank you very much, Jack, for confirming that. So I think it's quite important that we talk about how we can improve nutrition risk status awareness. Maria's kindly explained in a bit more detail as to why this is so important. But because this is so practically orientated, what we want people to do is to be able to go away and immediately do things that are going to make a difference to improving this nutrition risk status and awareness. So we have to ask ourselves the question, what helps to improve awareness of nutrition risk statement? And one of the most obvious things is, of course, providing simple written or visual materials that are going to help patients to understand what's going on, and also provide some triggers for those conversations that staff can have with patients. Because what we really need to be doing is doing things like explaining, both to patients and ourselves, how people can be malnourished and overweight at the same time. Practicing, for example, using respectful, non-judgmental diagnostic language that gives patients the opportunity to understand the meaning of their nutrition status, so that they can integrate it into the way that we're thinking. So to do that, for example, you can provide staff with scripts, training, visual aids to enable them to have those simple, uncomplicated conversations with patients that they're going to find it easy to understand. And importantly, involving the entire team in constantly repeating key messages. So one example is the idea that nutritional status is important, and it's so important that nutritional interventions, the things that the patients can do to help themselves, is to understand that nutrition is almost like the most important medicine they can have after their surgery. We can teach teams to think about linking nutrition risk to physical and functional recovery, complications, length of stay, and meeting patient-centred goals, some of the things that Maria's just been talking about. And we can make risk status really visible in the medical record and in other systems that surround the patient. And also include nutrition risk statement awareness in things like policy and care standards. And we can talk about that in a little more detail as we go along. So asking who can help improve nutrition risk status awareness, I mean, obviously that's going to be the whole team, but there are specific roles within the team that those team members can take on board and take forward with this issue. So, for example, doctors, medical staff, surgeons. The important issue is that they recognise and diagnose malnutrition or nutrition risk as part of the patient's medical assessment, and that nutrition risk is acknowledged in medical notes and in ward rounds, so that it becomes an automatic part of the way that everybody thinks about the patient, in the same way that they do about their recovery from surgery and as part of that recovery. And one of the things that we can do alongside medics is model, if you like, how to explain nutrition risk status. So having a way that's simple, that's understandable by patients, that staff can use to repeatedly explain nutrition risk status in a simple way. And the medical staff can also check that team members and patients are aware of their nutrition risk. Now, we've already mentioned in some of the things that Jack was just saying, that it's often nurses that are perceived as being the ones that are mostly involved in the kind of flagging nutrition risk in routine care, for example. And whilst that's not strictly true, we do have to acknowledge that it's nurses in hospital settings who are with the patients for 24 hours and are really there at every meal time. So nurses are quite central to this. they can identify and flag nutrition risk in all aspects of the routine care flows in terms of the patient's pathways and processes. And they can start nutrition care actions at the point of risk identification. And the most important thing about this in terms of fragility hip fracture, of course, is that the minute that you're aware that someone has a hip fracture, you can identify them as being at risk from that moment onwards. So automatically thinking, finding ways that people can be thinking, this patient has a hip fracture, let us link this very clearly to knowing that they're going to be at risk of malnutrition. So checking that all team members and patients are at risk, are aware of that nutrition risk, is then the next step from that point of view. And communicating their nutrition risk status during handovers and documentation in the same way that we do with many other things. You know, it's making nutrition central to all of the communication that goes on within the team. So other members of the health team who can help improve nutrition risk awareness are obviously dietitians. Their most important role is probably teaching teams to identify risk, diagnose malnutrition, provide diagnostic information, and perform specialist assessments. Dietitians are thin on the ground where they exist, and in some places they don't exist. So this is about dietitians where they're available, teaching the teams to fulfill that role in identifying risks and taking that forward. Speech and language therapists, for example, can do things like identify swallowing issues that increase nutrition risk. You know, and it's often a patient will have swallowing issues that have not really been identified in the community, that when they first come into hospital, they're identified, so action needs to be taken. Physiotherapists have an important role in specifically highlighting the role of protein in maintaining muscle. And once again, it comes back to this idea that nutrition's the medicine that you need in order to be able to rehabilitate and recover from hip fracture surgery. And occupational therapists will also link nutrition risk to functional recovery. Now, of course, support services also have a very central role. Food service staff, for example, reporting nutrition risk and flagging any concerns are really central. Clerks and admin staff, flagging patients at risk of malnourishment in records or systems, and even the IT and electronic medical records team can be very deeply involved in how to implement alerts and support team awareness and decision support to start treatments. And a lot of this, of course, is about, you know, we were talking earlier on about how, you know, things are really moving along in Ireland, for example. And that's because leadership and systems are very much on board with this. So in terms of people like hospital executives, you know, it's our role to make sure that they're aware that this is such a major issue and the impact that nutrition has on patient outcomes, so that they are able to understand the importance of allocating resources and supporting policies that improve nutrition risk awareness. So that education can be put in place where educators train staff and provide practical learning tools. That's all part of the Simpler programme. And already been mentioned, you know, auditing risk awareness practices and monitoring outcomes and supporting continuous improvement gives you the data to be able to ensure that both funding and processes and equipment and food and that kind of thing are in place to make sure that the expense of, or the minimal expense of doing this is warranted. And then, of course, involving patients and the wider community is really important. So patients and carers can be encouraged to ask about their own nutrition risk. and report their own concerns like a poor appetite or the fact that they've lost weight. And we can use advocacy groups, for example, to raise awareness of malnutrition and provide simple education tools for patients and carers that's then, of course, based in the patient experience. And of course, professional organisations can be involved by way of setting standards, and the Fragility Fracture Network certainly making really big inroads into doing that with the Simpler programme. So the next thing we need to ask is when and where can improvements happen? Well, in fact, all the way through the patient pathway is the answer to that. Because even at pre-admission, someone who's evidently broken a hip, it will mean that we can do things like identify that we know that this patient is already at risk, make sure it's documented and that it's shared with the interdisciplinary team, having that conversation, making sure that patients and families are informed about their nutrition status and treatment at the pre-admission and emergency stage can also be really important. And clear referral pathways should be in place for specialist nutrition care where it's required. And then moving on to the emergency department, again, the really important principle here is that all hip fracture patients are treated as at risk from the point of fracture identification, and that nutrition screening is part of routine assessment, even in the emergency stage, for all other fragility fracture patients, and that staff, patients and carers understand that treatment for malnutrition improves outcomes. That's the most important thing, isn't it? Better nutrition, better outcomes. Ward staff can be make sure that they check that all patients are aware of their nutrition risk by having those simple conversations that have been specifically designed for that. They can ensure that nutrition interventions have started. And going back to what we were discussing last week, that fasting avoidance has been become a priority, especially for those who are at risk and malnourished. In theatre and in perioperative care, surgeons and their perioperative teams should be aware of the impact of malnutrition on the post-surgical complications, morbidity, mortality and treatment costs, so that staff can prioritise avoiding prolonged or repeated fasting in at-risk or malnourished patients. And the treating team, patients and carers in the post-operative ward, can also make sure that they're all aware of the nutrition risk statements, and that patients at risk or malnourished are receiving simpler nutrition care actions, as we'll discuss over the coming weeks. And if nutrition intake is poor, they can ask the doctor to explain nutrition risk status to the patient. And finally, it comes to the likes of systems, policy and continuous improvement. Hip fracture policies and care standards can include nutrition screening and assessment as the priority. And then we can make sure that that's embedded in care pathways and workflows, and that nutrition risk status is embedded in electronic records and decision support tools, and again using audit and feedback. And importantly here, I know that it's likely that we have some attendees at the webinar who come from the kind of care settings that patients, orthogeriatric patients, go to after their hospital stay. So we need to be sure that when patients are transferring between care settings, a nutrition risk status is included in handover templates, and that there's an audit of the number of patients with nutrition risk status documented and included in formal handover information, and asking patients at discharge if they are aware of their nutrition risk status. So I hope that's given you a little bit of a flavour of some of the things that we can be thinking about doing in order to make sure that some of these things are embedded in practice really easily and using the most simple means possible.
Thanks so much, Julie, for that. That was an excellent series of presentations, and to Maria before that. So I hope everyone isn't too relaxed. Simpler is about action, not just consuming the knowledge. So we're going to put up a little bit of an interactive exercise on the screen. Hopefully that will pop up now in a second. But basically, these are practical tips to help you embed nutrition risk awareness in everyday care. Some of them represent good practice, and some, if you follow them, would be more of a missed opportunity. So have a look down through them and select what you think is correct for each of them. There's some great conversations going on in the chat as well, if people haven't been looking there. Especially interesting in the actual genuine food, freshly made milkshakes and protein cakes. Almost lunchtime here in Ireland.
I might actually have a go at answering the question from Malakoti.
Go ahead.
So, great question, Malakoti. So just while people are continuing to fill out their responses, the question was, can anyone share with me, how do you guys implement protein cakes and protein shakes? Most of the time, my patients don't like oral nutrition supplements and they don't finish up with their food portions. I won't talk to the food portions bit, but I will talk to the oral nutrition supplements. And it's very context specific. So I will just talk about what happens in our hospital. I know a lot of our patients in our hospital, if they don't know, and this is directly relevant to this topic, if they don't know that they've got malnutrition, which is one of the strongest predictors of poor outcomes after hip fracture, they're unlikely to engage with treatment for it. They think of the supplements more as a sweet food, and a lot of our patients in Australia are actually overweight and malnourished. And so they think it's bad for them to have the supplements and wonder why people are making them drink these drinks when they actually need to be losing weight. So at the point at which I get a phone call, or Sarah, who's also speaking in a minute, gets a phone call from the nurses to say this person doesn't like the supplement, can you change the flavor? What we usually do is we ask the doctors to review the patient and see if the patient knows why they're on medicine for one of the most harmful conditions that people can have when they have a fragility fracture. And I find that when my doctors go and chat with the patients, they decide that it's actually probably quite important that they do take their medicine, because they realize that looking after their last little bit of leg muscle so that they can get out of bed is an important idea. And so that means the dietitians are doing less what I call chocolate and strawberry waitressing, and we're using that as a medicine. But I also take Maria's point, which is about how you better deliver food and that crossover between supplements that can be both tasty and a medicine as well. And so some of these homemade kind of supplements can be very high in protein and calories as well. And so I can't go past mentioning Nottingham ice cream at the same time. So I'll say that for Apinda, who's one of the orthogeriatricians in England and in the UK as well. So at that stage, I'll see maybe, I know this one, we went a little bit early once last week. So Katerina, once you think we've got enough in, put it up. Other than that, I'll see if there's any other. Oh, yep. Okay, I'll stop talking.
I'm being told that light blue is good practice and dark blue is missed opportunity. So hopefully people don't have black and white screens or issues with this, but we can have a look. So treating all, so ones that are most around good practice, seems like everyone has been paying attention. So well done. So we've got treat all hip fracture patients at risk until assessed. Recognize that malnutrition is not always visible. Use visual cues, things like colored trays and prompts. Discuss nutrition during handovers and ward rounds. Involve patients and carers in conversations, and use system supports, so alerts, policies, and pathways. Ones that represent more of a missed opportunity, ones to avoid, skipping or delaying nutritional screening, relying on BMI or appearance, as Maria presented really well. Do not document or communicate nutrition risk, a definite missed opportunity there. And I think one people were maybe slightly more unsure of, but treating nutrition as separate from recovery. So hopefully maybe the future presentations we can talk a bit more about that, but nutrition is very much part of the recovery process. And so I think it is time to hand over to Stefano for the next talk. Well done, everyone, for your engagement there.
Hey, hi, good morning, everyone. I'm Stefano Eleuteri. I'm a psychologist from Italy, and today I'm going to talk about nutrition information, what it is, who should receive it, and how to measure it. So, of course, we know that nutrition information, as all the other health information, should be changed in order to be more effective. So, in this slide, you can find what does effective nutrition information look like. So it is important to use a simple, consistent language, to have the opportunity to combine written, verbal, and visual materials. It is important that, of course, we adapt also the material to the person we are talking with, and also to the possible barriers that we can have in the people from the different senses, for example, or from the capacity to understand what we are saying. It is, of course, important to repeat and reinforce key messages in order to have the opportunity that they can remain in the mind of the person, and also, of course, to do a consistent team messaging in order to maintain update on the aspects, and also to check the understanding of the person using the teach-back method, having as a feedback of what people can understand of what we already said. We already anticipated the importance to tailor the information to individual needs, so not just to adapt to the barriers, but also to give the information that they need. Of course, it is important that we always take in mind that most fracture patients do not receive nutrition information, and also that 1 on 3 of older adults have low nutrition literacy, and this, of course, it is connected to their health because it is linked to poorer diet quality, higher frailty risk, and also worse health outcomes. Of course, it is important that all patients with a hip fracture and also others at risk for malnutrition should receive information about their nutrition risk status, of course, adapting the information to what they can understand, to receive information that can support a treatment early in the possibility to change the decision, but also to take actions that can prevent their health, and also to understand why nutrition matters for recovery, strengths, and different possible outcomes. Of course, it is important that the information can be given in a practical way and not just from a theoretical one, giving them also some examples on how to have high protein, high energy foods and fluids, and also the possible oral nutritional supplements. Of course, the messages should be consistent, repeated over time, and also from the whole team that can give different kind of information. So, of course, in order to be possible what we already said, it is important that all team members should receive information in order to help them confidently communicate and support nutrition care, so that they can explain why nutrition matters for recovery and outcomes, outcomes, address the possible barriers to eating and drinking, and also to link nutrition to what matters to the patients, so that we can improve the proportion of patients who receive simpler nutrition care actions. So everyone should remind that every one of us has a specific role, so all the whole team should be informed and involved in order the patients to have the benefit. It is important also that we can measure the received nutrition information. For example, using the audit 10 charts, or ask also the 10 patients with a good memory. So, for example, have you been provided with information about nutrition, and giving us also the possibility to survey some of the clinicians at a team meeting, or using the simpler online survey, for example, what proportion of patients cared for in the past months are provided with information about nutrition, so we can be sure that everyone has been informed. Okay, so I finished for this first presentation, and now we will give also some information about received nutrition information and why it matters. So we have to remind that received nutrition information matters to patients, because help them to be engaged and to enhance the patients, but also the carer engagement, because they know also that they can do something, because nutrition is something that can change their health. So they do not have just a passive way of receiving health, but also an active one. It increases also the acceptance of the diagnosis. It can improve the understanding of their condition and care options, giving them the possibility to do choices for their life. It can also support informed consent and shared decision, and also can reduce errors, miscare, and confusion. Of course, it can also strengthen the patient-provider relationship, because, again, it is something that enhances the possibility of choices. And of course, what is really important is that it reduces the risk of malnutrition, increasing the physical and functional recovery, giving less time for the healthcare, and also reducing the complications and the mortality. Of course, it can have also an important organizational impact, because, of course, providing the right information at the right time. So we remember that we have to do it really in a first stage, and also at the right place. So, of course, in the important stage of the hospitalization, can lead to better nutrition. So, of course, it can support smoother the care pathways, reduces the staff workload from complications, increase the overall quality of care, and also, of course, it can promote consistent multidisciplinary practice, because it can help to have a role for everyone. Of course, it has also an important economic impact, with shorter hospital stays, lower complication rates, reduced readmission, because of course it can increase the health of the people, and also improve the efficiency of healthcare funding. Okay, I close because my time is finished, and I remain available for every comments and question. Thank you.
Thanks, Stefano. My name's Sarah. I'm a dietitian from Brisbane in Australia, lucky to work with Jack. And so to start off with, we'll go through a bit of a patient scenario that builds on the information that Stefano has shared with us. So I think that will pop up on your screens. So we have that Mrs. K is an 80-year-old woman, and she's recovering from a fragility fracture on an orthopedic ward. She lives alone, has mild memory impairment, and has been eating poorly since admission. Her daughter, who helps with her shopping and her meals, is present during the assessment. and a brief nutritional screen identifies her as being at risk of malnutrition. The team decides to provide targeted nutrition education for both Mrs. A and her daughter. And please select the response option that you think is most appropriate for this situation. And we'll just give you a minute or so to think about that.
While we're just waiting for that minute, I've seen your good question there, Giuseppe, and so I'm just looking up LeapSpace to see what the latest evidence says about self-reported heights and weights versus other methods. It's really a challenging process. Sometimes a self-reported height might actually be better than using a stadiometer because of the amount of kyphosis or curvature of a spine that a lot of our patients get. So I'm just going to have a quick look and I'll pop something in the chat in a minute.
And Katarina, do we have responses from most people now? Yeah, great, thank you. So we can see there that by far the most popular response was to deliver simple repeated nutrition messages and involving the daughter in that discussion as well. And so from what Stefano mentioned, we do know that that will really support understanding and retention of information there. So we'll move on to the presentation. So I'll just share my screen. Okay, so we'll now look at what helps, who helps, and when and where change can happen with respect to improving receiving nutrition information. So there are some strategies that we can use in our everyday practice to overcome some of the challenges that we experience when giving effective nutrition information. And so, as we've discussed, this can really be about using simple words, or where we do use more complex words such as malnutrition or even protein, making sure that we are explaining those to patients and their carers as well. Using short sentences and reinforcing our information using visual aids as well. Making sure that we're linking any of our recommendations around nutrition to a patient's goals. And when a patient may express concerns around a nutrition strategy, making sure that we're asking them about some of the reasons behind that, so then we can look to work with them to overcome that barrier. And a common one of this might be oral nutrition supplements, as we've discussed before. Making sure that we're involving our carers in the discussions around nutrition risk, especially when they might be involved in things like shopping and meals and supporting patients on their return back to home. And we can use that teach back method as well to help identify and then address any misunderstandings. And sometimes we know that using senior clinicians can be a way that we can build trust and confidence with the patient and their caregiver. And then also linking back our nutrition recommendations to NIC standards and guidelines. Where there might be some misinformation there, providing clear, simple, corrective information, but also making sure that that information that we're providing is consistent across our team members. If a person is from a non-English speaking background, making sure that we're using translated materials and interpreters. And we also know that using real life examples or patient stories can really be beneficial for patients and caregivers as well, to really help them understand the benefits of our nutrition information strategies. So when we look at who can help improve nutrition information practices, we do know that really it can be anyone from our interdisciplinary team. But then we'll look at some specific professions as well and the roles that can be specific to them. So everyone from our team can encourage patients to speak up about unnecessary fasting, for example, if there are delays in getting to their surgeries. Making sure that we're all explaining what nutrition status is and checking that our patients and their caregivers have a really good understanding of that. Making sure that we're explaining what high protein foods and fluids are, and again, checking their understanding, because without that understanding, those strategies won't be nearly as effective. And making sure that we're explaining the role of oral nutrition supplements and linking them to a patient's goals, whether that be, for example, goals around their function or their mobility or other goals that they have. When we then look specifically at the role of dietitians or nutritionists, our role is to really provide tailored advice for complex or high-risk patients, where those general strategies might need to be tailored or adapted to suit their specific nutrition needs. That could be, for example, a patient maybe who might need enteral nutrition, or a patient with severe liver disease or kidney failure. Then we might be looking at explaining and managing those nutrition plans for these more complex or high-risk patients. And a key one, as we've discussed earlier, is really making sure we're educating our team members on nutrition care, but also our patients and our carers. When we look at different doctors, so whether that be orthogeriatricians, surgeons, or more junior doctors, they can be great at linking nutrition to recovery and the role that it has in reducing complications, whether that be complications associated with the surgery or other medical complications as well. Linking back to the patient's goals and how nutrition can support them achieve those goals. They can also work with patients, carers, and other members of the team in nutrition planning, and then also identify and gently correcting any misinformation as well. There's lots of misinformation about nutrition out there at the moment, and sometimes coming from doctors. Some patients we know will listen to them more so than other team members. Nurses, they can really provide information about unnecessary fasting, nutritionary status, high protein foods and fluids, supplements, and post-discharge plans. They can really deliver and repeat simple, consistent messages during everyday care, especially as they are there 24/7 with our patients. Communicating that nutrition information across the care pathway, so from their admission through to discharge from hospital, and can contribute to communication improvement processes as well. When we look at other allied health, so for example, physios, pharmacists, and occupational therapists, their role can really be about reinforcing nutrition messages during therapy and functional tasks. They can talk about how nutrition can really help improve their strength and mobility and their rehabilitation outcomes. They can always ask patients if they know why they are receiving high protein foods, fluids, or supplements, and asking if they have received information about nutrition. And if they haven't, or they don't know why they are receiving certain foods or fluids, they can always provide some of that information themselves if appropriate, or refer them on to another member of the team who can provide that information. And then also our healthcare assistants and our catering or kitchen teams. They can often reinforce information about high protein, high energy nutrition messages, whether that be at the time of meal ordering or during meal delivery, to again just reinforce those messages. And so when and where can these improvements happen? And similar to our information about nutrition risk, this can happen throughout a patient's journey. So this can start in the emergency department, when we can talk about why unnecessary fasting is important, where we can start to provide information about their nutrition risk, and we can start to talk about our high protein foods, fluids, and supplements, and that they are provided to all patients. And these messages can continue throughout. With respect to the timing of theatre and perioperative care, we can start to talk about the importance of restarting nutrition early after surgery, about why it's okay to have nutrition supplements soon after surgery, and the benefits of having it. And they can also document instructions for the early recommencement of nutrition, and after surgery as well, so that this is communicated seamlessly throughout the team. When we're on the ward, we can link nutrition and we can link recovery goals to protein and energy needs, how it can help with their mobility and function. We can have our different team members and patients, again, reconfirming that awareness of nutrition risk and checking patients' understanding of why they are receiving these specific nutrition supplements and high protein and energy foods and fluids. And we can be having education within our interdisciplinary teams to make sure that all team members are providing consistent messages so that it's clear and not confusing to our patients. And then thinking about discharge, making sure we have templates to support clear, consistent handover of our nutrition information. We want to make sure that this information is communicated to ongoing care providers. We know that many of our patients, especially those who do have malnutrition, will require ongoing support once they have discharged from hospital. And we also want to make sure that the patient and carer are understanding of what needs to happen with nutrition after their discharge. And that is the end of my presentation. Thank you.
Awesome. Thank you, Sarah. I think I'm up. I hope I am. Otherwise, I'm making a grave error here. So apologies for anybody else if I'm actually butting in on you, but I'll share screen and we'll go from here. I was a little distracted by a great question from Ginny. Well, it's a statement from Ginny actually about who's a physiotherapist in the post-discharge space. So I'd just like to put a flag out. Last week, I did promise that I would make sure we wouldn't make these sessions just about inpatient care. And so it was really good to see that some of Sarah's slides talked about that. But I'll just reiterate that in many busy hospital settings, even if we give people a diagnosis, they often don't remember. There's so many things that go on. So please, if you're working outside the hospital, it's not too late to check at least to see if people are receiving diagnostic information and then information about nutrition, because the next study that I haven't done yet is to show just what little information, when we provide lots of detailed information to patients when they're inpatients, they don't remember very much. If we get the team to say, as Stefano said, five or six different people say the same short thing, they're more likely to remember. But definitely continuing that through into the post-discharge space is what is most important, because that's where it's probably going to be remembered and will probably also lead to some more meaningful lifestyle changes. So on that note, I'll try and share my screen as well. And wow, I've got way too many screens open at the moment. So hopefully this will work. Okay, so Sarah, I'll get you to check because I've got a different view here now. Hang on. Just trying to get my slideshow up. Okay, looks like that's working. Is that working okay? Great. So I'm now just going to talk about the simpler steps to improving nutrition risk awareness and receiving nutrition information. So this is really, you've heard a lot about what can be done, what could be done, what should be done, but how do you actually make this happen where you live and work? Because even the hospital down the road from our hospital does things differently because it's a different context. And so what's important to know is that we actually should take away the information that we're hearing in these webinar series, but then make it your own. You need to take it to your teams, which is why it's so important to look at your own data using those simple measures that we've spoken about earlier. So firstly, form a simpler improvement team. So get together with a few of your motivated colleagues. Don't make it a massive group. Don't make it too formal. Rather than having minutes and agendas, maybe have biscuits and coffee. That will work a lot better. Trust me on this one. And then, you don't, 2 to 4 people is enough. And whoever you've got, if you've got people that are motivated, it's more important that they're motivated rather than they're from a specific profession. That would be another tip I'd give there. Next, confirm who should be aware of nutrition risk status and receive nutrition information. So for the sake of time, I've bundled these both together, although on our quick start guides, these are done separately. But basically anybody who's had a recent hip fracture should be considered at risk of malnutrition until assessed as well nourished and not at risk of becoming malnourished. And so there was a conversation going in the chat about that. And there is no perfect screening tool, but especially in fragility fracture and especially in hip fracture patients, we know that for many different reasons, the tools aren't as effective as what work in many other populations. So, but then we do say for the non-hip fracture patients, use a valid screening tool, and those just also remember that people who are overweight or living with obesity can also have malnutrition. And so there was also a bit of a conversation going on about heights and weights. And sorry, Giuseppe, I think it was, you pressed one of my buttons, which was around BMI being used as a standalone measure. And I know that's not what you were asking. So that was just not in relation to what you said, but more broadly, we do know that if we rely on using BMI in our hospital, the cut point for malnutrition, which is actually quite sensitive, is a BMI of 26. So in our patient in Australia, if you're an older person and if your BMI is less than 26, you have a high probability of being malnourished. Now, there's no screening tools out there that use cut points that high, so they need to be revised. And then finally, anybody assessed or diagnosed as malnourished clearly should receive information about their nutrition risk status and receive information about nutrition more generally, as long as they've got a good memory and a good understanding and they want to receive it. We still should ask if people want to know. Next, set a simpler aim. So, for example, within 2 months, half or more of our hip fracture patients with a good memory will receive reporting information about their nutrition risk status and information about nutrition. The reason I've chosen a patient-reported measure there is there's an emerging amount of data that's coming out. Not all of it's published yet, but it shows that whilst we write in the charts that patients have been provided with information about their nutrition risk status, often they don't actually report receiving that information or being aware of it. And so I'm going to give some kudos to Sarah, who's actually doing a PhD in this around this whole topic of diagnostic terminology. And so keep an eye on what Sarah will be publishing, and is already publishing, but over the next couple of years, there's some exciting work to come out here. Then test, choose, and collect measures. So like I said before, my favorite one for these two is to ask the patients. But you can also audit 10 charts or survey 10 clinicians at a team meeting. And we've got some examples of questions there. It's not research. If you ask 10 clinicians at a team meeting, or well, you've already seen the survey results from what we did at the start in the poll. So why would you need to do a 100 chart audit in a poll if you know that all the clinicians are saying that everybody is not aware of their nutrition risk status and nobody is receiving nutrition information? You know you've got a problem. You don't need to go and triangulate it. If it's not really clear, then maybe rather than doing 50 charts, instead triangulate it from another source. So if you did a chart audit, maybe ask some patients, or if you ask the clinicians, maybe do a chart audit. So there's different ways to do it. But this should be able to be done in 1 to 2 hours. 2 hours if you're doing it by yourself, 1 hour if you're doing it with a friend. No matter where you work, it doesn't take long. You will be very quick to find if you've got a problem. Then select, test, and implement changes. Now, I do not expect you to try and read that fine print, and I'm definitely not going to bore you to tears reading through all of those, other than to say, we've done a lot of behavior change theory and looked at barriers and enablers to come up with implementation science-driven ideas, what teams can do to change things for better. So don't try and do them all at once. Sorry, I'm getting ahead of myself here. But basically just you can also work with your team and patients and carers and find your own. But whatever you do, just pick one, select it, test it, learn and adapt. Try it for a couple of patients or for part of a day. Again, it's not research. And then review and keep going. So compare your before and after with those little tests. This isn't like, 100 patients before and after. It's like 5 patients before and after. Did it seem to make a difference? If it did, great, keep doing it. If you're not sure or something needs to change it. And if it was totally not very successful, just stop doing it and try doing something else. If it is working though, please tell others, but don't tell them what to do, because it might work in your setting, but it might not work in theirs. So in summary, if you want to improve the number of patients who are aware of nutrition risk status and have received nutrition information, don't get complicated. Keep it simpler, because we know better nutrition leads to better outcomes. Now, did I just manage to stop sharing, or am I still stuck on a share screen at the moment? Okay, great. So I'll just now pull up my Word document so I can see where we are next.
I think it's time for the commitment activity, Jack. Do you want me
Excellent.
to come in and intro?
That's excellent sharing there, Mary. Thank you so much. You've saved me. I've got my document.
No problem. So just, I think Katerina is going to share a little activity that hopefully we'll have been able to think during all the presentations. So can you complete this sentence? Oh, it's not. We're going to do it in the chat.
In the chat, yeah.
So one change I think we could try next week is.
And sorry, Katerina, I forgot to talk to you about this one. I think maybe next week might be a bit tight, and that's my bad. So I'm happy for people to even go with one that might take you 6 months, but you think's really worth doing, or one that you think you might be able to do in a fairly short period of time. So as you've listened, if there's anything that stands out to you as, oh, actually we're not doing that, but that's worth a try, pop it in the chat and see where we go from there. While people are thinking, I see Gio Raslan has put in a very challenging one, which is actually shifting things out into the community with Health Force working, training and education, patient and family nutrition health teaching programs, client assessment and documentation procedures need to be reviewed. And they are all, you've got about, I reckon, 3 to 5 years worth of nice hard work there, Gio, but between yourself as the lead of nursing for this area in the Philippines, along with Erwin and some of the others who are leaders, I think you'll be up to the challenge. So I'm very happy to talk to you about this out of session as well. I did promise to someone last week, like I said, that we need to shift things beyond the 4 walls. And so this is a really good process, both for inpatients and outpatients. The other option might be as well, if people did want to talk, you can, I believe, raise your hand. I'll double check. Is that right? I know I can raise mine, but if anybody does have any other questions, and if you just want to say aye, although I know there's like about 60 people on, so you might not want to do that as well. Okay, so I see somebody's put in there forming a team. It's definitely one of the first parts of the model for improvement. So So I think that is a great place to start. Yeah, great. And then we've got another one, which is about talking about nutritional risk for every patient in the board rounds, and raising awareness with team members as well. And that's really helpful. Thanks, Maria. I think that's a great commitment, and no pressure to the doctors in the room here, but I know our older people, especially if have been on lifestyle diets, such as for heart disease or for diabetes and different things, it can be quite challenging to then think that you're supposed to eat more protein and more calories. And so having that explanation come from a trusted source, such as the treating doctor or surgeon, can be very powerful. As a dietitian, sometimes it can be quite frustrating because we think people, should do what we say, but really in the end, a lot of my patients are older people who very much cherish what their doctors say. So if a doctor 10 years ago said you need to go on a low fat, low cholesterol diet, they're very unlikely to have high protein and high energy foods and fluids until that's reversed by the medical staff. What I might do, I can give everybody probably an early mark here, is I hope you've had a chance, even though there's not much in the chat, to just self-reflect. What I think I would encourage, and you could just send that just to me if you want to, or to everybody. We are learning as we go with these particular webinars. So if it's a bit threatening or just a bit too much to take in all at once, we can reframe this last section of our slides to move away from putting everybody on the spot and making a commitment on the chat as well. So if you think we could do something better with this last little slot, please give us some feedback about that. Okay, so there's a great one there. So share with the nutritionist in our team about Simpler. So maybe, yeah, we can combine that with another one and bring it in so they're part of the team and forming the team. So yeah, great. Okay, so they're starting to come through. Maybe my just internet was slow. Great. Okay, so while people are still thinking about that and putting down some commitments, I will just pull up the closing slide. Nope. This one. Okay, so thanks all for dialing in. It's been a pleasure having you here, and I really do hope that you will be going away from here thinking it's not just good enough to give someone a high protein diet or to put an oral nutrition supplement down on the table and walk away. Malnutrition is a disease, some people call it, others call it a condition, but it is one of the most harmful diseases or conditions that people can have, especially if they have a hip fracture or just are older and multimorbid in general. If people have cancer, well, if I had cancer and if somebody told me that I had a lump in my neck and I should start getting radiotherapy and I should have all of these chemotherapy agents that are going to make me very sick. And if I just had a lump in my neck, then I'd probably go surfing and not worry about it. But if somebody took the time, and I'm not going to say what word is used, but if somebody took the time to explain to me that I had a condition that was actually very harmful and there are potential treatments for it that can make me have a better chance of recovery and meet my personal goals for life, then I would pay attention to what they're doing. And so the same goes with nutrition. Nutrition is one of the most harmful things that people can have, but most of our patients are not receiving information about their diagnosis in a way they can understand. And most of our patients are not receiving information about what their treatment options are. So across the world, we are spectacularly failing at informed consent and shared decision making for the most vulnerable group many of us will ever get to the pleasure of working with. And together, by making things simpler, we can actually do something about that for better nutrition and better outcomes. I'm not just saying that because, I'm trying to self-promote. As Mary said, it's going viral across Ireland at the moment. And that's because the clinicians have realised what's going on. They've looked at their data, they're horrified, and they're doing something about it. So please, even this week, go away and do an audit of 4 or 5 people in your ward even and see what's happening and see if they are risk aware and if they have received information. Once you get that data, you'll be able to hopefully do something about it because your team will be engaged to drive those changes. So next week, we will be talking about receiving high protein foods and fluids and oral nutrition supplements. Please feel free to invite your friends or colleagues. The recordings of this webinar will be sent with a follow-up email. If you've implemented anything, we'd love you to tell us about it. So you can scan the QR code now and the link to this activity form will be sent to you shortly. Otherwise, like I mentioned before, please give us feedback for the session by completing the brief survey that will appear on the screen after the end. We will review those and we will adapt according to your feedback. And if you want to know anything more about Simpler in general, just go to our global hub. It's continuously updated. It's not overloaded with a lot of information. There's only a few select things there. And if you'd like to get involved with in any global region, you can actually register your interest there as well to help roll Simpler out more broadly. So apart from that, thanks again so much for coming in and wishing you all the best of your morning, midday or evening, depending on where you are in the world. Thank you.